So now let's discuss abnormal pregnancies. So first one is partial mole. In partial mole, there is fertilization of single ovum with two sperms, which called is triploid with dispermic fertilization. That is 69XXX or 69XXY. And in partial mole, some fetid parts are still present as compared to complete mole, where there are no any fetid part are present. In complete mole, an empty ovum is fertilized with single sperm. Then what happens is then duplication of that sperm occurs. And here all genetic material is from paternal side and no contribution from maternal side. In complete mole, as we discussed earlier, no fetal part are present, and there is characteristics no storm appearance in complete mole. And the complete mole is associated with choriocarcinoma, which can lead to lung metastasis. So we need to do chest X-ray in case of iridiform mole if we are suspecting choriocarcinoma to rule out metastasis. Alright. Then this is molar pregnancy. In molar pregnancy for the management of molar pregnancy, we do curettage and then we check serial beta HCG level. And because even though there is a chance of conception during this period, so we need to give contraception while on surveillance. While the patient is on surveillance, so we need to give extra contraception to the patient. And then next one is twin pregnancy. In twin pregnancy, chorionicity and amnionicity depends upon the time of zygote, and we already know this. I hope you all know that whether the fetus will be dichorionic, diamniotic, or monochorionic, diamniotic. This depends on the time of the division. If it occurs early, then there will be two placenta, two amnion. If it occurs late, then it will result in single amnion and single chorion. So, the monochorionic diamniotic one is associated with twin transfusion syndrome, and monochorionic monoamniotic associated with cord entanglement. So, we need to do C-section early, like 36 to 37 weeks, due to the risk of cord entanglement. And if both fetus are cephalic, then we can do vaginal delivery. But if first fetus is breech, then we need to do cesarean. Because if first fetus is breech, then there are more chances of complications in the vaginal delivery. So we prefer cesarean delivery in case if first child is breech. Now let's discuss different types of abortion. What's the definition of abortion? The abortion is basically loss of pregnancy before 20 weeks of gestation. And in cesarean abortion, there is pain and mild bleeding, and on examination, os is closed and uterine size is equal to period of gestation, and fetal cardiac activity is present. There is type of abortion. We advise bed rest to the patient and give progesterone, but fetal cardiac activities is still present. In inevitable abortion, there is pain and bleeding, but os is open and product of conception bulging is cervical os. Os open and product of conception is its cervical os. On ultrasound, non-viable intrauterine gestational sac lower uterine cavity is present. If patient is hemodynamically unstable, then we do curettage and sectional curettage in case of inevitable abortion. Otherwise, if the fetal cardiac activity is not present in this case, ultimately we do this will lead to abortion in any case, loss of the fetus. Alright. And then incomplete abortion. In incomplete abortion, there is a history of passage of fetal part, like mother will see that I passed some solid white mass. There's a history of that present, and os is open, and some parts are intrauterine and some are expelled in case of incomplete abortion. No fetal cardiac activity on ultrasound. But in complete mole, because there is complete loss of the pregnancy. So ovary is completely closed and uterus is completely absent. And the size of the uterus is completely normal as of normal person, not the uterus of the pregnant size. And in this case, there is a history of passage of the flaky mass. Also, the fetus is lost completely, so there is a history of heavy bleeding in passage of flaky mass in case of complete abortion. After complete abortion, uterus is of normal size and HCG is of normal range. Nothing is in favor of pregnancy in case of complete abortion. In missed abortion, there is no bleeding, no pain, and decreased sign of pregnancy like vomiting and breast tenderness. And ovary is closed, and ultrasound will show empty uterus or embryo without cardiac activity. Or abortion has already occurred, but mother has no idea what has happened. In this case, if the gestational sac is present in the uterus, there is no cardiac activity. Ultimately, we will give further like mifepristone and misoprostol to the patient for the completion of the abortion. Alright. Then let's discuss systemic disease in pregnancy. So, in polycystic pregnancy, there is severe itching on the body, including palms and soles, and diagnosis is made by increased total serum bilirubin level. And for treatment, we give ursodeoxycholic acid. In case of polycystic pregnancy, severe itching, we give ursodeoxycholic acid. Now, in acute fatty liver of the pregnancy, there is severe epigastric pain with hypoglycemia, thrombocytopenia, and increased level of transaminases. This is an emergency situation. Patient has decreased blood glucose level and severe pain and thrombocytopenia. So we need to do urgent delivery in this case. In acute fatty liver of pregnancy, we need to do urgent delivery to avoid fetal distress or any other harm to the mother. In post-dural puncture headache, patient present with the headache after anesthesia. Post-dural puncture headache is common presentation in mother who receive epidural anesthesia during vaginal delivery. It is positional headache, so it means it gets better when patient is in supine position and gets worse when she stands up. And as a self-limiting condition, so no specific treatment is required in this case. All we do is advise mother to take rest on the left sacral position, and it will get better with time. Another complication of epidural anesthesia is hypotension. Sometimes what happens is sympathetic chain also gets blocked, and this results in severe hypotension in mom. For that, we need to do intervention, like we need to give IV fluid in bolus form, and we need to give vasopressors to increase the blood pressure. Otherwise, it can become deteriorating. It can become harmful for the mother. So we need to intervene in this case. Okay, so EPLA is an antiphospholipid syndrome. It is one of the causes of recurrent pregnancy loss. Also, it's a prothrombotic state. So, for the prevention of thrombosis, we give low molecular heparin in case of EPLA. Last one is amniotic fluid embolism. Amniotic fluid embolism happens when amniotic fluid enters into the maternal circulation. When it happens, in case of the abruptio placenta, amniotic fluid can enter into the maternal circulation, which results in DIC in mother. It is a very dangerous condition. It presents with hypotension, bleeding from the punctured sites, and hypoxemia. And for diagnosis, we do coagulation studies and we give respiratory and hemodynamic support to the mother because it's a very dangerous condition. There is hypoxemia and hypotension, so we need to manage urgently in this case. Then delivery. So in this slide, I have discussed what are the indications of cesarean delivery, what are the indications of urgent delivery, and how you manage, how you deliver twins and dead fetus. So indications of cesarean delivery are classical cesarean section, is a history of classical cesarean section, history of myomectomy with uterine cavity invasion, and when the first twin is breached. In case of placenta previa and rasa previa, as we discussed earlier, in both of these cases, we do elective C-section before the onset of contraction, like before 36 or 37 week of gestation. And in case of footling breach or in case of arrest of labor, how we define arrest of labor? Like greater than 4 hours of adequate contractions in primary of adequate contractions and greater than 6 hours of inadequate contractions. This is known as arrest of labor. So in all these conditions, we do cesarean delivery. What are the indications of urgent delivery? Chorioamnionitis, acute fatty liver of pregnancy, oligohydramnios in late term, and late deceleration or sinus wave pattern in baby on CTG and eclampsia. In all these cases, we need to do urgent delivery. Depending on the condition of the baby and the mother, we will decide whether we do cesarean or vaginal, but we need to do urgent delivery. So in twins, if both are syphilic, then we do vaginal. If first one is breached, then we do cesarean. For dead fetus, we do induction of labor, but first demise should be confirmed on ultrasound. If it's confirmed that baby is dead, then we will do induction of labor with oxytocin in artificial rupture of the membrane. Then patient with cervical surgery or it increased risk of preterm labor, so transvaginal ultrasound should be done to measure cervical length and assess the risk of the preterm delivery. Then spontaneous preterm delivery should be managed with progesterone and serial cervical length measurement. Because there is increased chance of preterm delivery, so we need to do serial cervical length measurement and assess the risk. For preterm labor, if it's less than 32 weeks or if it's less than 34 or 37 weeks, then we need to give, if it's before 32 weeks, patient is present with labor, it's preterm labor, so we give steroids, penicillin, sulfate-based streptococci, magnesium sulfate, and tocolytics. If it's present less than 34 weeks, then we give steroids and penicillin, and if present at 37 weeks, then we give only penicillin, because there is no any advantage of giving steroids and magnesium sulfate after 34 weeks, after the maturation of lung. So we only give penicillin prophylaxis for GBS, group B streptococci. Then CTG is there's normal range of CTG, normal range of heart rate and variability. Normal heart rate is 20/160 and normal variability is 5 to 25. And normally what we call the reactive CTG, it is called reactive when there are 2 accelerations in 20 minutes. Decreased fetal movement is alarming sign and should be assessed with non-stress test. If non-stress test is undiagnostic, then we do biophysical profile. And if biophysical profile is abnormal, then there is a high chance of fetal demise, and then delivery should be done urgently in case if biophysical profile is also abnormal. Alright, so then early deceleration shows sleeping, shows whether the baby is sleeping, or in case of head compression. In both of these cases, we find early deceleration. Second one is sinusoidal pattern. Sinusoidal pattern is present in severe anemia. In sinusoidal pattern, if the sinusoidal pattern is present on CTG, then we need to do urgent delivery. Late deceleration shows due to placental insufficiency like placental abruption.